It is a pleasure to have the opportunity to introduce our distinguished guest speaker, Dr. Abdalla Sholi. Dr. Abdalla Sholi is a hematologist oncologist. He's the regional director of the UPMC Hillman Cancer Center in North Central Pennsylvania. Dr. Sholi graduated from the University of Jordan Medical School and finished his residency in internal medicine at Temple University Community Program, the Scranton Temple Residency Program. In 2003, Dr. Sholi completed his hematology and oncology fellowship at the Medical College of Wisconsin, Milwaukee. He practiced hematology and oncology in private practice and hospital-based practice. Dr. Sholi is a member of the UPMC Hillman Cancer Center in 2019. Today, Dr. Sholi will talk about managing fertility issues and breast cancer treatment during pregnancy. Welcome, Dr. Abdalla Sholi.
Hi, how are you, everybody? I'm great. I'm very happy to be here, and I'm glad to discuss this very important topic, and we're just gonna immediately dive into it. So we're gonna start with the pregnancy-associated breast cancer, and then we'll go on to some fertility issues that happens with different cancer treatments. So breast cancer or pregnancy-associated breast cancer, it's a breast cancer that occurs during pregnancy or within the first 1 to 2 years postpartum. It's not that very common. It happens in almost 1 in 3,000 pregnancies. It's usually ranked around the second most common malignancy that complicate pregnancy. It seems to increase as women delay childbearing into the 4th and 5th decade of life. Usually presents as a probable finding. So people feel a lump. The problem with the pregnancy, the breasts themselves are pretty dense and nodular, which kind of delayed the diagnosis, which is kind of a hallmark of this disease. Seem to be they present a little bit later because of the younger age of the patient and the difficulty of the breast, the density and the nodularity. But if you do feel a lump in the breast, you start with the examination. You can go forward with imaging and eventually a biopsy. And your goal is eventually to biopsy any palpable finding. That will be your ultimate goal. Breast ultrasound carries sensitivity and a negative predictive value up to 100% in pregnant breasts, which is very comforting to know. If a suspicious finding is identified, a diagnostic mammogram is indicated. MRI with gadolinium is kind of contraindicated in pregnancy. MRI without contrast is safe, but I don't know how much of the breast tissue you are going to show very accurately. Why is gadolinium kind of contraindicated? Because it crosses the placenta and enters the fetal circulation and amniotic fluid. They seem to be, we're not sure about the long-term effects, but some people mention, or some trials, or some case studies mention increased risk of rheumatological or inflammatory conditions. If you happen to have an MRI with gadolinium postpartum, you should not interrupt the lactation because of gadolinium exposure. There's no evidence that it's harmful postpartum. But as you said before, if you have any suspicious mass or imaging finding, you should always attempt to biopsy it with no fear of local complication to the breast, even if you suspect a breast, anything to do with the milk. If you suspect, there's no long-term complications or damage to the breast. 70 to 100% of pregnancy-associated breast cancer usually present as infiltrating ductal carcinoma. That's the main pathology that you'll see. It's usually hormone negative. I mean, estrogen receptor positive, ER negative, estrogen receptor negative, progesterone receptor negative, and HER2 positive, which is similar to an age-matched control. So remember, those are younger females, and those tend to have hormone receptor negative, HER2 positive types of breast cancer more commonly than older females. Prognosis for pregnancy-associated breast cancer is similar to age and stage match controls. A meta-analysis found a higher mortality and recurrence rate, but included older studies with delayed and less effective treatments. 21% of stage of the pregnancy-associated breast cancer, usually within stage 1 and 2, versus 54% in non-pregnant women. And you see the difficulty here in identifying females with a younger, earlier stage because of the earlier problems that we mentioned. 53 to 71% with positive nodes. But it seemed to me that the worst prognosis of pregnancy-associated breast cancer is most likely due to the stage diagnosis and the subtype of cancer than the actual to do with the pregnancy. And terminating the pregnancy does not improve the maternal prognosis. So that's not really something that we do just to terminate the pregnancy. Usually we try to continue with the treatment and try to maintain the pregnancy. And now, obviously, if this happened within a week or two of being pregnant, a lot of discussion can be made up then. But for the most part, pregnancy termination does not improve maternal prognosis. The management of pregnancy-associated breast cancer requires a multidisciplinary approach. So you need a whole bunch of doctors all together. You need to have a specialized radiologist, a breast surgeon, and an anesthesiologist, a medical oncologist, which is me, an obstetrician, a maternal fetal specialist, a pediatrician / neonatologist, because remember the babies, if they get delivered after chemotherapy, within a few weeks afterwards, they may need special attention, especially with the blood cells, and also finally a social worker. So you have a whole lot of approach needed here, a multidisciplinary approach. Genetic testing for inherited breast cancer is usually indicated considering the younger age and the higher risk type of breast cancer that usually presents. So when you diagnose breast cancer, you always try to stage it. Obviously, your main concern at this stage is fetal radiation exposure. So you could easily do an ultrasound of the right upper quadrant, looking at the liver. You can have a chest X-ray done with an abdominal lid shielding, and you can have an unconscious MRI of the bones if you suspect an area where, God forbid, an area of bony metastasis. You can probably do it then. And if you look here, it's a little graph which shows you the different stages of pregnancy: 8 weeks and 15 and 25 weeks. At no time you should have a lower lower abdominal CT scan. That's contraindicated pretty much all through pregnancy. You could argue about an upper abdominal CT scan. I'm not a fan of it. I think you should, if you want to staging, stick with an X-ray, a mammogram, an ultrasound, and that's pretty much it, as we said. Again, you can see the radiation exposure along the way. So if you want to treat pregnancy-associated breast cancer, obviously surgery is one of the main modality of treatment and one of the more effective way of managing it, and should be chosen by the same principles as a non-pregnant female. I mean, being pregnant does not give you only one option. I mean, if you would think about breast conserving surgery versus mastectomy, that's usually kind of the same guidelines between the patient and the surgeon should follow regardless of the pregnancy. Small series have confirmed that equivalent survival between pregnant women undergoing mastectomy or breast conservation surgery. If chemotherapy is indicated, post-mastectomy radiation can be given after completion of chemotherapy and delivery without any delay. So you can always do the chemotherapy, you can have the surgery, chemotherapy, and do the radiation after the baby is born without significant delay. Sentinel biopsy is pretty safe and accurate for clinically node-negative patients. Fetal radiation exposure after radionucleotide injection are within usually acceptable levels. Isosulfan blue and methylene blue should be avoided because of the teratogenicity. Axillary dissection should be reserved for known axillary disease due to risk of lymphedema and low therapeutic benefits, and even that can be discussed with the surgeon. Anesthesia is pretty safe during pregnancy, and there are multiple large trials that established the safety and anesthesia during pregnancy. Surgery by itself is pretty safest around the second trimester. And don't forget, those patients have a higher risk of thrombosis being pregnant, also having a diagnosis of malignancy, which increases the risk of thrombosis. So you always got to think about thrombotic prophylaxis during surgery. So if you decide that you should do chemotherapy, adjuvant chemotherapy, or for that matter, neoadjuvant chemotherapy, so adjuvant after resection or neoadjuvant before resection, the dose should not be altered during pregnancy. Remember, there's an extra water weight in those patients, but your dosing should not be altered. The safest time to get chemotherapy during the second and the third trimester, not before 12 weeks. Does not increase the rates of fetal loss or congenital anomalies above background rates of 3 to 5%. The fetal and neonatal echocardiogram does not show increased fetal cardiotoxicity, especially with the use of anthracyclines that we use frequently for breast cancer. So it does not affect the baby's heart as bad as we think it does. Almost all intravenous cancer therapies cross the placental barrier and have fetal effect, including doxorubicin and cyclophosphamide, which we use very frequently. As we said before, cytotoxic chemotherapy should be delayed until at least the second trimester, kind of above 12 to 14 weeks. There's less data regarding the taxanes exposure in pregnancy, but small series suggest similar safety profile to doxorubicin and cyclophosphamide. And we do use taxane during pregnancy. It's pretty safe. I've used it. And it's pretty widely used in those patients with no long-term complications. Dose-dense chemotherapy, which is sometimes we use in breast cancer, which is more compact way of giving chemotherapy, shorter period between the cycles, may improve the efficacy of treatment and shorten time to completion, but the higher risk of maternal toxicities like neutropenia, infection, sepsis, effect on the blood, anemia, all those kind of a concern when you use dose-dense chemotherapy. Small retrospective cohort study of dose-dense chemotherapy in pregnancy found no difference in fetal or maternal complications, but was significantly underpowered. Just keep in mind, those patients are a little bit you don't want to make everybody extremely sick during that period. So if you have to do dose-dense chemotherapy, you should be okay, but I would be extra careful. Just keep in mind, supportive agents are safe in pregnancy with low risk of congenital anomalies, like anti-nausea medication. You have ondansetron, metoclopramide, GCSF to treat neutropenia is quite safe. Erythropoietin, I'm not sure I would use in early stage breast cancer, but it is safe if you want to use it. Methylprednisolone, hydrocortisone, diphenhydramine, and ranitidine, all safe during pregnancy. So if you have to use those with your chemotherapy, you should be okay. Trastuzumab or Herceptin is contraindicated in pregnancy. HER2 receptors are expressed on fetal renal epithelium. It does decrease the fetal urine output and amniotic fluid volume, which increase fetal lymph malformation and pulmonary hyperplasia. No studies exist for pertuzumab in pregnancy. So that's a little bit of a challenge if you are HER2 positive, and the fact that you can't use any of the drug that targets HER2 receptors. That's a problem, and you have to delay that treatment until after delivery. So even if we're not going to do chemotherapy, we need to talk about using endocrine treatment. Tamoxifen is contraindicated in pregnancy. It's category D. Reports about neonatal ambiguous genitalia and oculoauriculovertebral dysplasia. Case reports used in metastatic setting without fetal harm, but there was a small series. Tamoxifen postpartum may delay milk production with no data regarding safety in lactation. If you have to use it, you use it probably postpartum. In 2010, if you want to think about do adjuvant radiation treatment, in 2010, International Congress concluded radiation may be relatively safe in first and second trimester if you have to. Radiation always can be delayed after the baby is born. Just keep in mind a delay of treatment of less than 3 months may be acceptable with a calculated 1% increase per month delay in local recurrence risk. So you literally have 3 months safely. You can delay the radiation with minimal increase in local recurrent risk of recurrence. Most significant fetal sequelae of pregnancy-associated breast cancer are from iatrogenic prematurity. It's having the baby early from complications of treatment. Delivery is optimally 3 weeks after you give chemotherapy. You're going to try to time it to give the baby at least 3 weeks before being delivered. So if you think about it, you want to deliver the baby around 37, 39, 38, 39 weeks. You want to stop at 34, 35, and then have the baby after that. The mode of delivery is entirely by the OB, the obstetrician consideration. There's no advantages of doing of a C-section versus vaginal. It depends on the OB, whatever they were supposed to do. It should not interfere with what we did. Keep in mind, though, contraception needs to be needs of the mother should be addressed immediately postpartum. 33% of women ovulate before their first menstrual cycle postpartum, and due to young age, chemotherapy may not induce permanent ovarian failure. Actually, most of the time, if you are below 30, it's not going to induce any ovarian failure. IUDs, copper, or progestin should be used safely in those situations. A lot of time you want to mention it during the time of delivery, rather than wait until they come back afterwards. You can discuss that with the patient, but keep that in mind that they need contraception. You probably don't want them to have another baby on top of what they had, especially in the midst of not fully treated breast cancer. And this is kind of a diagram that shows us kind of a different scenario, and it depends. Again, your management will depend on the time of diagnosis. If it's a first trimester, early second and third, late third. So you want to, as we said, you want to do the chemotherapy pretty much by the second and third trimester, and you can wait for the delivery after delivery to have the radiation and endocrine treatment. You can always fit also neoadjuvant chemotherapy if the diagnosis is made in the early second and the early third trimester. You can talk about neoadjuvant chemotherapy, having the surgery, and then having the chemotherapy afterwards. So you gotta plan your treatment options basically depending on the presentation and the type of cancer that is presenting and what kind of the modality of the treatment. But your options are pretty open between surgery, adjuvant chemo, neoadjuvant chemotherapy. And remember, there's always having things to be done after the baby is born. And this is kind of a quick thing to remind you of things that you could do during pregnancy. Surgery, you can have surgery anytime with no problems. Radiation, you can do the first 2 trimesters safely. Do not do anything in the third trimester. Obviously, we're not going to radiate anything in the pelvis. Chemotherapy, we try to avoid the first trimester. You can do it safely in the second and third trimester. Targeted therapy, as we mentioned, is not supported due to limited evidence. The only targeted things that we could use safely in pregnancy, which has nothing to do with the breast cancer, are rituximab and imatinib. Those are pretty safe in pregnancy, which has nothing to do with the breast cancer. Overall prognosis, and this is the overall survival and disease-free survival. And if you look at it here, if you look at 60 months, you're talking about between 75 and 80% overall survival. If you look at the disease-free survival at 60 months, you're talking about close to 65, 70%. That will tell you, again, remember those patients have an hormonal negative breast cancer, and a lot of them are HER2 positive breast cancer, present later, and that's where we're saying it's a worse outcome due to the disease itself rather than the pregnancy. Now, we're going to switch gears a little bit to risk of infertility in women. The female fertility can be compromised by any treatment that decreases the number of premolar follicles, affect hormonal balance, or interferes with the functioning of the ovaries, fallopian tubes, uterus, or cervix. The natural decline of oocytes with age, if you look at it at birth versus a 50-year-old, you can see it's a natural decline. It's gonna drops down with age. Chemotherapy-related amenorrhea may be a permanent or temporary. It's a CRA, or chemotherapy-related amenorrhea, is an imperfect surrogate for menopause and infertility, and fertility, because it could be temporary, and it doesn't mean you're into menopause, it doesn't mean you're basically infertile. So you have to keep that in mind. Accurate assessment of ovarian function has implication for family planning, treatment, hormone-sensitive tumors, and other survivorship concerns. And here, if you look here, the risk of amenorrhea is related to age and treatment. So the older you are, and the more treatment you get, the higher the risk of amenorrhea you're going to get. So, for example, if you look at age 45, if you use hormonal and chemotherapy, you're like 80 to 90% chance you become amenorrheic. Versus if you're below 30, it's almost close to zero. And again, everything depends on the age of treatment and the type of treatment you're going to use. And here are the a few things that will kind of causes ovarian failure. The things that considered higher risk for ovarian failure are total body irradiation, obviously, high-dose cyclophosphamide, chlorambucil, melphalan, busulfan, nitrogen mustard, procarbazine. The low or no risk methotrexate, 5-FU, vincristine, vinblastine, which is used in Hodgkin's lymphoma, bleomycin, actinomycin. That's pretty safe. Intermediate risk is cisplatin, carbo, or doxorubicin. Unknown risk about ovarian failure are the taxanes, oxaliplatin, irinotecan, monoclonal antibodies, tyrosine kinase inhibitors, which should not really induce ovarian failure, but it's we don't know. And again, here, if you look here, the more complicated the chemotherapy, the more chemotherapy we give patients, the higher the risk of ovarian failure or amenorrhea. And if you look here, for example, AC or 4 cycles of adriamycin cyclophosphamide, if you're below 30, really it's undetectable. Versus age above 40, more than half of the patient became amenorrheic. We don't use a whole lot of CMF anymore, but if you look at AC and Taxol, you talk about 38% overall, 15% below the age of 40. So the more chemotherapy we use, the higher risk of amenorrhea that happen. And in closing, just keep in mind adjuvant endocrine treatment for breast cancer, like tamoxifen, does not cause permanent amenorrhea, but it requires a lot of planning because those folks are young, they want to have more kids. So you're going to have to time it and discuss with the patient what your best treatment options are. And it's always a challenge treating younger patients with breast cancer, especially with the pregnancy and ovulation and having babies are included. And hopefully that was helpful. And thank you.